Welcome, sir. Please come.
Good afternoon, respected seniors, my colleagues and my junior colleagues. First of all, I would like to thank the organizers for giving me an opportunity to share something with you people. And most of the times my lecture will be non-linear and unconventional. Most of the lectures will be linear and conventional, but mine will be always. Just now, actually, Dr. Rakesh has spoken so nicely about artificial intelligence. Even in the post-lunch session, actually, he made us to be awake. Listen to him. Actually, it was a wonderful lecture. And now from AI to, we will concentrate more on EI, emotional intelligence, because we need something. Always I say, for my postgraduates and juniors, if you want to be relevant in the wherever, in the profession or society, you have to be different. See, doing different things is always difficult, but doing things differently is comparatively easy. That's what actually, we are all know, so many blocks we are giving in our institutions, so many of our teachers are teaching our blocks, but actually where to give it is more important. We are always forgetting about the pain of the patient, and we are trying to always assess in a scientific way, some methodology that this, we are worried about that actually. Pain is, that's why always the best definition of pain is what patient says it is, close. That's all actually it is. It may be something very severe for somebody, somebody may not be so severe. We cannot judge on them. It is actually, if he says pain is there, whatever pain intensity, that is we have to accept it. See, when patient is posted for neuraxial blockade, especially when they come for fracture femur, fracture tibia, or so many other fracture neck of the femur and other things, especially elders, we don't care about their pain. We shift them on the trolleys, take them to the X-rays, take them to the CT scan, MRI, wherever we want, everywhere we will be shifting them. We are least bothered about their pain because we are not able to give them much of the analgesics, which we know maximum we use is tramadol, diclofenac, all those things in the emergency room, or even when we are positioning the patient before giving neuraxial blockade like subarachnoid block or epidural. Actually, why block before block? This is a new concept. Actually, it is coming out everywhere nowadays. Future fracture femur, most common orthopedic injury. It is then, especially it is a severe pain it causes due to the periosteum, lowest pain threshold, somatic structures. Then proper positioning for SAB and EB, this is very much required. And especially in an institution where postgraduates, we are training the postgraduates, we ask them to give the spinal, subarachnoid block or epidural block where they take hours together. One of the reasons because of is not a proper positioning of the patient. We are not able to put the patient in a proper position. That is also one of the reasons they are not able to give the subarachnoid block or epidural block. Failure. Okay? And it is so severe pain, we are least bothered about their emotions. I told you, from AI to EI, we have to give a little bit of importance for their emotions. We have to use our emotional intelligence to take care of their pain before positioning them. Especially overriding of bone ends during positioning worsens pain. Where all we can give blocks before block? One is hip joint fracture, femur, common orthopedic injury, neck of fracture neck of femur, and even the same technique can be used in emergency room. It is called as on-arrival blocks. Nowadays it is very popular, developed by, I think published by Ganga Hospital. And even the ward, we are using it to alleviate the pain. And of course, operation theatre for positioning of the patient. How many of you are giving femoral block here before positioning the patient? It's good actually. See, always we know pen block, suprainguinal fascia iliaca block, and femoral block. These are the very commonly used blocks nowadays. These are all, but we are not using it most of the time before positioning the patient or before giving any other regional blocks. We have to start using it. Actually, it gives such a wonderful relief for the patient. Still, we have to take care of there because of the other things. What are the blocks before block? One is femoral block, infrainguinal fascia iliaca block. Third one is suprainguinal fascia iliaca block. Fourth one is pen block, pericapsular nerve group of blocks. Femoral nerve group, indication for hip, femur, anterior thigh, knee, patella, fracture and procedures of anesthesia and analgesia. It can be used as an anesthesia and analgesia also. Little bit of anatomy we should know it before doing it anything. Most of the people know about giving blind technique also of femoral block, and ultrasound has given us an edge in giving more and more blocks. We know that vein from medial to lateral, vein, artery and nerve. Actually when you give femoral block, actually it gives a most of the area of the fracture is covered, and that's why patient feels most of the pain is relieved. 60 to 70% of the pain is relieved, but not 100% always, but it is far better compared to other. See, this is just if you know how much femur covers and what are the area obturator nerve covers and what are the other areas where sacral plexus covers. Femoral block, we know it is a blind technique, and also with the ultrasound. The ultrasound technique is very easy nowadays. It is with the stimulus needles we can do it wonderful with peripheral nerve stimulator, where 99% of the success you get it, and it is always stays next to vein, artery, nerve. These are the pictures I am showing it. Actually we know where directly we enter into the femoral area and femoral nerve area and give the injection. That is one. And these are the blind techniques where you can give femoral block. See, just to try for the patient who is posted for surgery with the fracture neck of femur or fracture femur, any area. Just observe the patient's face. He will be so comfortable in sitting position, especially when we are giving epidural block, because it takes usually, whatever it may be, it takes minimum 5 to 10 minutes. Otherwise, it is so difficult for them to be in the proper position and also in the care comfort. And infrainguinal fascia iliaca block is not much practiced, but still, one of my postgraduate did a dissertation on this. See, the position of the probe you can make out. That is for, actually, this is infrainguinal, that is suprainguinal. Above the inguinal ligament, when it goes further, that is the suprainguinal. When it comes below, infrainguinal. And also, there are another different techniques we can follow it for suprainguinal fascia iliaca block. This is where we inject the drug in the fascia so that it gradually comes and covers the femoral nerve. But always, as a conclusion, he has come in his dissertation also he published the paper that direct femoral nerve block is always far better than the infrainguinal fascia iliaca block. Suprainguinal fascia iliaca block, this is supposed to be called as advanced block. They are teaching in most of the workshops. The position of the probe is very, very important. What you have to do is, first you have to focus the anterior superior iliac spine. Then just you come 1 to 1.5 centimeter medial, then around 2 to 3 centimeter down, just above in between the inguinal ligament. Your probe must be, linear probe must be there. Then you can see the picture like this. You can see beautiful picture like this, pelvic brim and iliac muscle and internal oblique transverse abdominis muscle and also sartorius. It is a bow tie like picture. You can see that, and deep circumflex iliac artery pulsation also you can make out. But you have to inject the drug. When you enter from this side, you have to inject the drug beyond this area to get a supra-iliac fascia iliaca block, actually, SIFI block. Because the advantage of SIFI block is it covers femoral, obturator, lateral femoral cutaneous nerve of the thigh. All three nerves major nerves are covered in that except sciatica. See, this is the proper way of doing it. The needle is here, you can see the drug, and unzipping of the fascia, you can see here, and so beautifully it is opened. And another most popular block is pen block, where it is actually indicated in right capsule, ileum and acetabulum, partial anterior hip pain. Okay. This is the anatomical land, anterior, inferior iliac spine and iliopubic eminence. In between there, actually we are going to keep our probe, and we can see the nerve. We block the nerves which is placed to the head of the femur. And indications are intracapsular hip fracture, hip arthroplasty and arthroscopy, analgesia, chronic hip pain. What is happening is most of the anesthesiologists, we do whatever, we are restricted to the things which regularly we are doing it. We don't want to go out of our comfort zone. Try to do something which gives wonderful analgesia for the patient, so that what is the advantage is actually patient starts recognizing us. Because it is my personal experience in so many years, because especially when we were in Tamil Nadu, actually one day suddenly when I was going on the road, I parked a car, somebody came in the doctor, Tamil day he was telling it. Because elephant attack it was actually. Like that actually you can get the recognition, but we are not doing it. When we don't do anything other than the routine things, then automatically we will be behind the mask. Behind the screen, behind the mask always. These are the nerves which we are going to block during the pain. Femoral nerve, accessory obturator nerve and obturator nerve. That's why it covers almost 70 to 80% of the nerve supply to the head of the femur. There are different types of, you can go keep your transducer position to perform the block. It is one is transverse oblique, sagittal and sagittal oblique. This is the most commonly I use this one or this one techniques usually. This gives a wonderful picture, and you can have and I prefer always curvilinear because it covers the wide area, so that you can see the needle and other structures, femoral artery, everything you are able to see when you are giving block. Curvilinear provides a wider and deeper field of view. This is what we are performing in a patient. Curvilinear with the peripheral nerve stimulator also we use it. This is the picture you see in a pen block, where psoas tendon, iliopubic eminence, anterior inferior iliac spine. In between that you get a cup-like thing which is called as iliopsoas notch. If your needle comes from this side, you will infiltrate the drugs here, so that psoas tendon becomes very clear. When you are injecting, you should be very careful. If they get resistance, means your needle is hitting the bone or inside the tendon. You should be careful about that. Just withdraw for mm, 1 or 2 mm, and flow must be very smooth. You can see the femoral artery also. If you inject the drug for 10 to 15 ml, it gives a wonderful analysis. This is the ultrasound picture, it is not so clear. 10 to 15 ml is enough for the, whereas suprainguinal fascia iliac block, it is because of the fascia iliac block, it is a plain block, but give more volume, 30 to 40 ml, depending on the patient condition and the age. And whatever drug, opioid, whatever drug you want to use it. These are the few papers we have published on the ultrasound guided femoral block versus intravenous fentanyl, ultrasound guided pen versus CP, and the same thing, using different things. That's why actually, see, what positions, what we have is not important. What gives the comfort to the patient is more very, very important. And when you are putting the patient, after giving block also, sometimes patient complains the pain, not because of the fracture part, sometimes because patient is lying down since long hours, his erector spinae muscle might have gone for the spasm. That's why you have to put the patient slowly into the position. Otherwise, suddenly if you push them or pull them, then they will have a severe pain because of the erector spinae and other thigh muscles. You have to take care of that pain also, proper positioning, then automatically your success rate increases, and also patient comfort will be far superior when compared to other techniques, whatever IV analgesics and other things. And I conclude that actually it is blocks before block, that before giving Subarachnoid block or epidural block is always gives a wonderful comfort to the patient, and it is a great gift we can give it to the patient. And also we are doing something different in front of others, also is sometimes needed. Thank you for patience hearing and not sleeping throughout my lecture. Thank you, Ananda.
Thank you, Dr. Vasantha Kumar, for your nice presentation, illustrating the ultrasound diagrams and actual photo pictures. And it's really, any questions you can ask?
What's the concentration you're giving and whether you're adding any additives also?
Additives is, we are adding actually dexamethasone, but dexamethasone, fentanyl, but old age fentanyl I try to avoid always. But dexamethasone is giving a wonderful analgesia. Post-operative also around 8 to 10, sometimes 12 hours we are getting when we are giving before.
Concentration also?
Concentration 0.25%, because not much relaxation is required here. 0.25 is enough. The volume is more important here actually.
Is there any complications with the blocks for so many years?
Tomorrow we have punctured, PGs they have punctured. I have taken the care of that one. It is my responsibility. But CP and pain, we never had any. It was a wonderful pain relief patient going to get.
Thank you very much, sir.
Thank you, sir. Thank you.
One question from my side.
Sir, please.
Before giving this nerve block, what is the percentage you don't need subarachnoid or subdural epidural block?
Sir, I didn't get you, sir. Before
You have blocked the nerve. Now after that, here it should be supported by subarachnoid or epidural block.
yeah. Intraoperative.
Intraoperative.
Intraoperatively, when we are giving this, actually what paper we published is, we have not given any other supportive analgesics. Before that, actually we have assessed the pain, comfort of the patient and pain relief. We have not given any analgesic intraoperative. And post-operative only, first rescue analgesic was taken as the duration of action. And especially very useful in the on-arrival block, emergency room, it is very useful. Start practicing it. It is very good for younger generation. Little bit of extra, you have to come out of your comfort zone. Of course, you have seniors has to support you when you are interested to do something. It is our responsibility to make you people to do it.
Thank you very much.